So, welcome to week 8. Week 8 is an interesting week. It's GI and GU. And there are some similarities with the adult world in them, but many of them aren't. There's a lot of interesting diagnoses that you won't see, but only in the pediatric population. Now, those in Professor Morris's class, I will be sending you a matching. Now, this matching is 20 different diagnoses, like intussusception, and then you match it with what it is. So it goes through the book, all those topics you need to know about. It gives you those key points. So I'll be sending that to you so you have it too. My class already has it. I always tell them at the end of class, go through, check them, see which one you already know, and then you know what you have to study because you have it there in front of you. All the things that you need, 20 different things, and it actually goes with the book as it goes down. I made it myself, and I thought it was a really interesting tool for y'all to have. So, I'm Professor Bogart. I'm your lead pediatric professor. Professor Morris and I were born on the same day, the same year, 6 hours apart. We're both very similar. And we've been working together now since 2020, since right at COVID, and when the pediatric program opened. So we're very comfortable with each other. So, we both teach differently, but we both, are very determined to make all of our, not make, but to help, assist, and guide all of you to get through pediatrics. I mean, we're happy when we don't have any failures. We really are, because we hurt just as much as you do, believe it or not. So, week 8, as I said, quiz 5 will be next week. Now, I have my students are going to be doing this week's information. I'm sending 2 guides to Professor Morris. She can make up her decision what she wants, but she'll send you an announcement what to study for the quiz. This week is the clinical pediatric assessment, and it is 3 different things you have to do. One is a 250-word APA type of paper. 250 words is nothing. Make sure it has a minimum of 2 references. There is a assessment form. It's on the modules, and it's 11 pages, but a lot of circle, circle, circle. What we do ask as you're filling it out, after you picked your topic and you got approved by your professor, that those systems of the body reflects the diagnosis that you've told us. For instance, if you're giving me a project all about asthma, the lungs should be what an asthmatic child should sound like: expiratory wheezing, retractions, tachypnea, coughing. That would be what I want to see. If you have a child who's, you're doing cognitively delayed, let's say Downs, well, we know that leukemia and hypothyroidism are 2 different things they could have. So when we get to endocrine, you could say thyroid hormones are normal. And remember, endocrine is always growth and development. Growth, which means height and weight. That's why we do height and weight on all of our children on every visit, whenever they go, ER, urgent care, or the physician. We do it because we're looking at many things, but one of them is growth hormone and your thyroid. So those are things that we want to see. Make sure that you put your nursing diagnosis related to as evidenced by. And then there's 2 sections for Piaget and for Erickson. What should they be at that level, but what are they exhibiting? If you have a cognitively delayed child, autistic, Downs, they're not going to be on that level. So explain it to me. And then the end column tells me, because of that, how are you going to help that child be more relaxed and less stressed in a visit with you, okay? But any questions, ask or send it to me. I don't mind. I've been looking at projects partially done, sending back feedback. So if you want me to look at it, I don't have to be your professor. Send it to me and I will help you with it. And then you also have that SC pediatric assignment. Sam is one of the ones that's in Evolve. 70 or 80 questions. So we're starting to get you prepped and ready to the end of the quarter and also getting ready for your HESIs. So how do I teach? Well, I'm going to do a PowerPoint. I'm going to go over it. I do not read a PowerPoint. I'm going to give you the gist, and I'm going to give you stories of things that have happened to me during my career. And I think that makes you understand more of what these diagnoses are. And then I have a Kahoots immediately testing you. I don't know if you've ever opened my Kahoots and looked at them, but you absolutely should. Concepts of every exam are all over those Kahoots. If you understand Kahoots, you're going to do okay with the exams. Also, Professor Morris, her handouts, all that information covers everything in your exam. So, and then I have my PowerPoints. If you want them, you can have them. Again, I make sure information is placed there that you understand. So any questions so far? Now, on Professor Morris's class, I will be sending you the video recording today. I usually do it soon after class. I do teach another class right after this one. So by about 9 o'clock tonight, you for sure will have your recording. I will also attach again that matching sheet. And I also will attach the PowerPoint. So you'll have all of my information if you want to go back and look. I do have a YouTube channel if you ever want to look at any of my week anythings. And actually, you can go start ahead and look at all the HESI prep stuff there if that's what you want to do. Some students like to work that far ahead. I'd get through exam 3 first, right? Remember, next week we're doing our reviews. They're starting. I've started to post them already. I think Monday at 9 a.m. is the first one, and it goes through either Saturday or Sunday. So they're all over the place. So let's go ahead. Remember, when I'm teaching at any time that you don't understand, I want you to ask me, okay? If you don't understand, I'm sure somebody else also doesn't understand. So, slideshow from the beginning. All right, I think my new computer's gonna work for me. I just kept the same system, same HP, and said, I hope it works. So, GIGU, we are on week 8 already, and it goes by extremely quick. And with that being said, let's go into, first of all, is GU. Now, GU is all about genitourinary, which means your kidneys, your ureters, your bladder. It also goes into males, their penises, and certain conditions that occur. We'll go over those. We know the biggest thing when we think about urinary tract and we think about children, especially girls, is urinary tract infections. Urinary tract infections, most common, many reasons. Well, think of the young kids, they're potty training, right? And as they're potty training, are they, wiping themselves the right way? Also, potty training, are they emptying their bladders fully or are they keeping it in there? So that's part of it. Bubble baths, wearing tight underwears. They say cotton underwears is the best for little girls. Now, also, one of the high level groups of incidents of urinary tract is uncircumcised boys that are young. Now, when you have a boy born and they're not circumcised, they have this foreskin, which is fine. But parents, mothers need to pull down that foreskin every day and wash underneath it. There's this white cheese-like substance called schmegma that builds up there. It's like a petri dish, so it grows bacteria. So grows bacteria, then it creeps up, goes into the urethra, and then it goes into the bladder, and now we have a urinary tract infection. So that's why. Another thing that we have seen is that in any infection, whether it's that strep infection, we're going to go into some of those things today, or urinary tract, make sure the child finishes all the antibiotics and then gets checked to be sure that the infection's gone. So any kid who's showing things like wiggling, holding themselves, keeps running to the bathroom, or they're incontinent when they've been potty trained for a while, something's going on. Then you get closer to them and then you smell, oh, the urine's not good. And then you could say, yes, urinary tract infection. Parents need to know what these signs are so that we can treat them quick. You know, young children don't have a huge immune system. We know as we get things, we build up immunities. As we get our immunizations, we build up immunities. So, with urinary tract infections, it can go up into the kidneys and really damage them. So, we want to get to that with antibiotic as soon as we possibly can. Again, it's just simple cleaning, taking baths, wipe the front to back. It's making sure that they empty their bladder. One of the things is actually making sure they're moving their bowels regularly. That's a big thing. Now, adolescents, I've seen in my career, sometimes you have these young adolescents coming in and you remember them because they've had a urinary tract infection. And now all of a sudden, you see them back with another. Now, a lot of girls aren't going to be telling you, yes, you're having sex, but when the parents goes out to get a cup of coffee or something, I would say, so why do you think you're getting all these urinary tract infections? And I said, you can be honest with me. I don't have to talk to your mother about these things. And if they tell me they're having sex, one of the things I would tell them is to urinate as soon as possible after intercourse. They say it decreases the incidence of urinary tract. Now, what do? We evaluate, you've got signs and symptoms. We know this child's urinary tract infection. We need to get a urine and we need to do that culture and sensitivity of it. We want to find out what antibiotic works the best with it. Now, a suprapubic aspiration. This is what we use for those young, premature infants that a little catheter, in order to get a clean catheterized specimen, there's nothing small enough for them. So if you have a 600, 700 gram infant, they're a little over a pound. So what they do is they put sterile gloves on, they clean the area above the symphysis pubis, and they stick a needle in, a syringe and a needle, stick it in and pull out just a little bit of urine. And that's good enough to get a really good urine specimen. So we get a culture report and the antibiotic know we're giving the correct one from as soon as we get that culture. Sometimes we go into the kidneys. Sometimes we put catheters in the older children and we put saline in it and swish it around and get what's debris and stuff that could be in there. That can help. Ultrasounds and voiding cystourethropographies, they're looking for structural problems. Is it the ureters? Is it the bladder, or also called vesicle? Is there connections are wrong, kinks, or non-openings, atresia, stenosis? All of those things can cause problems with the urinary tract. IVPs, intravenous pyelographies, those are usually for your kidney stone. And of course, we have scans we can do. Now, sometimes we have to go ahead and do a renal biopsy, whether it's for resistant urinary tract infections. I've seen it done that. You want urine right from the source where maybe that's where the infection is. Or, of course, cancer. That's another way we would do it. But it's extremely similar to the way that we treat cardiac cath children. So they go to the surgery or the procedure. They usually are under sedation because they are going into the back with a needle. They want them calm and they come back. They have, same like a cardiac cath, a pressure dressing and a sandbag if that's possible. Of course, you're going to be monitoring vital signs. It always will tell you something, but bed rest 24 hours because that kidney's been punctured, probably a clot's formed already, and then of course there can be some bleeding going on. Now, another thing, besides just looking at the dressing, we're also going to be looking at where does urine and blood go if it's leaking into the peritoneal cavity. Well, you're going to see it with abdominal discomfort. So we're looking out for that also. Be telling us something's going on, something's leaking. In infants, we literally do an incision because it's hard to find that tiny little kidney, and we'll get it, and there usually will be sutures there. So we'll be monitoring for pain, tenderness, intake output, and we'll be watching for any drainage on that bandage, that pressure bandage. As I said, obstructive uropathy. Now, I love this picture. This is from your book. You have kidneys, you have ureters, and then you have a bladder called a vesicle. So sometimes, most common, that vesicle ureteral junction, sometimes that sphincter does not work right. One side, both sides. And that creates urine to go up and down, up into the kidneys, up the ureters. And it's we don't want that to occur because actually they say that the vesicle, the bladder, is not as sterile as would say, your kidneys. Okay. So we don't want it to go up and down. Now, nephrotic syndrome is a condition. It's not treatable as in cure. We do treat the symptoms. I want you to know it has nothing to do with kidney failure. Again, nephrotic syndrome is nothing to do with renal failure. The kidneys work, but the kidneys say, yuck, protein, I don't like you, and I'm going to excrete you. Well, where is protein? Isn't that the albumin, the protein in your intravascular space in the blood? That's where we put drugs that they go on to albumin, and the rest is free drug. So no albumin, no protein in the blood system. You're going to have to use decreased dosage of medications, or they can become toxic quick because the protein's not there. Also, because it's messed up that isotonic between intracellular, extracellular. So it goes intravascular and fluid gets pushed interstitial. So you have generalized edema because there's no protein. The body's trying to equal up here and it can't. And of course, you're going to be urinating and it looks like beer, foaming. It's just so much protein. Now, they do consider these children immunosuppressed, so they're at high risk for infection. So, as nurses, we must make sure that we do proper care. Now, a lot of times they get swelling in their mouths with this generalized swelling, and then they bite on their, gums and their cheeks, and it hurts and it's, discomfort, and they lose their appetite. So that's why loss of appetite. Now, fluid restriction, because it's all interstitial. Yes, you're getting rid of protein, but you got all this extracellular, interstitial fluid generalized all over the body. How do we treat that? Well, we're going to restrict the salt. We're going to restrict fluid. Anytime you work with fluid problems, one of the nursing care things that we need in the care plan, intake, output, daily weights. If the daily weights maintain, you're not losing fluid. If they're starting to decrease, we know that some of the fluid is being pulled off. Actually, the immediate care for a crisis of nephrotic syndrome, they're somehow all of a sudden they come in and they're swollen, is actually corticosteroids, and that's how they treat it. And of course, the whole family needs support. So we don't want the protein to go out. We want to reduce all that fluid retention. One of the ways that they pull fluid out of the interstitial space is by giving them liquid albumin, right? There's 5%, 25%, and that starts to change the isotonic, hypertonic solution, starts pulling out fluid from the interstitial space into the intravascular area, through the blood, into the kidneys, and now we're getting rid of fluid, okay? Now, when we give this albumin, just to speed up that diuresis process, they'll give some furosemide, some Lasix to follow. Very common. 5% albumin, wait 10 minutes, give the furosemide, and you're going to watch your output come out. So our goal is to minimize, prevent infections, and of course, strict INO and daily weights. Very important. Now, I talked about finishing antibiotics. This is one of the ones that we need to make sure that parents understand they need to finish their antibiotics. and that's strep throat. A streptococcal, hemolytic streptococcal type of a group B strep, they call it sometimes, but it's an infection that sometimes children don't even get treated. It's a sore throat. They say, just gargle, you'll be fine. Take some, Tylenol, Motrin, and it sort of goes away, but not really. What happens is this strep infection, two things that we know about now, causes rheumatic fever, right? It attacks the heart valve muscle, the mitral valve, and it causes what we call a carditis. The whole heart gets inflamed with it. The other thing that a strep infection that has not been properly treated is acute glomerulonephritis. Now, acute glomerulonephritis can be turned around, okay? But it can turn into chronic, which will be a lifelong now mission to treat it. What is glomerulonephritis? Oliguria. They're not urinating. Of course, you have your edema. With anything holding fluid, hypertension is one of the big things. And specific to glomerulonephritis is that periorbital edema. You'll see these big swelling around their eyes. You might see some hematuria, like a red-bound urine in color. And again, you will see that protein increase in their urine. So we figured out it is a strep problem that caused glomerulonephritis. What we'll do is long-term antibiotics to treat that strep. As I said, usually they say after 1 year, if the kid has not, turned around and the kidneys were treated with strep and it's working, they're still not gone. That will be a chronic disease, as I said. So again, fluid balance problem. They're not urinating. They're getting swollen. Daily weights, intake output, right? These are key nursing things we must do. Also, low sodium fluid restriction. We don't want to do everything we can to increase the amount of fluid being retained. And what I said even with this one, they are very similar to your nephrotic syndrome, susceptible to infection. So as nurses, that means washing your hands, using gloves. If you have a cold, put a mask on, right? Protect. Wilms tumor is your nephroblastoma, right? This is a cancerous tumor, mostly Afro-American children, and usually around 3 to 5, but 3 is that ripe age, more in boys. I've seen one in my career, and the child had come from Haiti right after the earthquake, and a religious group brought him to the triage area in the ER where I was working, and all of the paperwork was in French. These people had no clue why he was there. They said, pick him up, bring him to my hospital, and bring him to the ER. And they did it. And I felt his abdomen on the left lower quadrant, felt like a softball sized cyst. And for some reason, I knew it was a Wilms tumor. The problem with Wilms tumor is very fragile. Too much manipulation of the abdomen can cause pieces to go off, and now you have causes metastasis. So do not palpate that abdomen. Once you know, leave it alone. They'll do chemo, radiation, one or both, and then they'll remove it. And they do really well with that removal. Now, there's acute kidney failure caused by something, and then chronic, usually a congenital abnormality. Now, acute was all of a sudden where you stop urinating. I mean, that could be that acute glomerulonephritis, right? That is a renal failure if you think of it. They're not urinating. I've actually seen one case where it was ibuprofen, believe it or not, that caused this. It was an older adolescent, but this child was having a history of kidney stones and took ibuprofen, and he hadn't urinated in 3 days. They stopped the ibuprofen, didn't realize that what it was, but in the hospital, I guess they gave him something else, or it wasn't, as painful, but they're not getting ibuprofen anymore. And on the 3rd day, this child started urinating again. So it could be that. It could be constant reflux into the bladder up into the ureters and the kidneys. It could be structural. It could be all these different things that can cause it. Now, one of the things that can cause acute renal failure is dehydration. You think kids, they're always vomiting diarrhea, and it's like, okay, just give them some liquids, they'll be fine. And they continue to vomit. It gets to the point where the whole body and the organs are not being perfused. And that causes this renal failure, this, acute stage of it. So we have to rehydrate. We take dehydration very seriously. As I said, chronic, you're born with it usually. And they say it's less than a 50% capacity. And it goes, more and more as time goes on and on. They call it uremia. As I said, it could be hereditary, pyelonephritis, acute glomerulonephritis. Well, think about lupus. Lupus attacks all the organs. It attacks kidneys too. And then anaphylaxis. That's one of the things. So in renal failure, we know that we are in it. The kid's not urinating, it's showing all the signs and symptoms of it. Our goal as nurses is to, with these children and medically, keep the kidneys working as much as we can. And it's that fluid and electrolyte imbalance that we really have to keep that fine line, making sure that their electrolytes are okay. We know potassiums go really high with renal failure, right? So we really have to be aware of that. Also, the kidneys aren't producing the erythropoietin like it should to produce red blood cells. So we can give sub-Q injections of that. And again, always treating whatever we see as soon as we can. Now, many of these older children are in these dialysis units 4 hours a day, 5 hours a day, 2, 3, 4 days a week. So a normal active lifestyle is possible in between all of that. Now, infants are born congenital, right? They can have a chronic kidney failure. Prune belly is actually one of the diagnoses that I've seen with this. And what they do is they'll do peritoneal dialysis. They cannot do the machine hemodialysis in infants. That flow, that blood flow in and out causes turbulence. And their brain, their vessels are very fragile and they just explode. So now you have all these interventricular hemorrhages and bleeds in the brain. And of course, that can cause cognitive delays, et cetera, et cetera. So peritoneal dialysis is pretty neat. It's a tube that goes into the abdomen, but the big thing with peritoneal dialysis is to maintain sterility all the time. We cannot leave that one place, that the abdomen is the only kidney they have. Without that, they're going to die because we can't do anything else. We have to preserve the peritoneum. So we take warm fluids, we get dressed up, we put hats on, we put gowns, we put gloves on, we open everything sterilely. We've got it all connected. We have warmed fluid and we connect this warm fluid on this machine to the end of that little tube there. And that's a very good depiction of what it looks like. And then we put the machine on. And what it does is we call cycles. And we do them at night. And usually there's 8 to 10 cycles at night. So that warmed fluid, whatever the fluid the nephrologist wants them to be on, it changes all the time according to lab values. But we put in that amount of fluid. On an infant, it might be 100 mLs, right? They put it in, and then it's what we call still, or it sits there inside 20 minutes. And then we do what we call drain for 20 minutes. So 20 minutes you put it in, 20 minutes it sits, 20 minutes it drains, one cycle. You can do 8 to 10 a night. When we measure, and that's usually connected now to a Foley catheter bag. So we know 10 cycles times 100 is 1,000 mLs. The difference between the fluid in the bag and 1,000 is the urine output. So it's really monitored great. I've seen one mother, amazing, in one of the clinicals that I did. A kid was 2, finally ended up with a kidney transplant, but that child never ever had an infection at all, which I think is extremely commendable. The big thing is that infection. So, how would a kid with peritoneal dialysis, how would you know they have an infection? Well, first thing you might see is a drainage fluid color change. It could have speckles in it, it could get more yellowish. It should be clear. That's what it should look like, with maybe a little bit of tan or yellow in it. But you start seeing stuff like sediment, you start seeing color change immediately. Call the doctor and get an order for antibiotics. You can't give antibiotics until you get the order from the doctor. Usually it's this questions about what would you do? Many students will say, we'll give antibiotics. Well, no, you got to call the doctor and then you can give the antibiotics. And these are handled at home so well. So what best describes acute glomerulonephritis? What's it caused from? Anybody?
B.
Yep, it's due to a streptococcal infection. How do we treat it? Treat the streptococcus, right? Let's give some antibiotics. All right, GI. When we consider the GI system, gastrointestinal is from mouth to anus, so everywhere in between. So, nutritional disorders. Well, where is nutrition absorbed in the body? Mouth to anus, right? So, part of it. Now, we need to have proper vitamins, minerals, and calories in order to grow and to be cognitively, alert and, be the best you can be, right? Yes, there are problems with cancer, HIV, sickle cell, cystic fibrosis. Well, you can go to celiac disease if you want, low birth weight, things that affect the way that nutrition is absorbed into the body will produce nutritional disorders. So, celiac disease. Celiac disease is in the small intestines. That's where all your absorptions of food and minerals and vitamins are, right? And we have the duodenum and the common bile duct, and all of those things are pumping in whatever enzyme they need in order to digest food. Well, the problem is there is no the ciliary in that area does not like to absorb fat. So think about fat in just nutrition. We have 1 gram of carbohydrates or protein is 4 calories. 1 gram of fat is 9. So you can see you're not getting calories with celiac disease. Also, too much gas that's not been absorbed, you're going to see what we call steatorrhea. Think about the worst smelling stool that you've ever smelt. That's pale because it's not absorbed completely, all the nutrients, and very bulky. Absolutely, classic what you see. With too much fat in the body, you get gas, you get abdominal distension, and of course, you're not getting fat vitamins. So it's going to be needing some of those supplements. How do we treat it? Well, no wheat, rye, barley, or oats. So nothing with bread. But rice now has those things, and rice is a really good alternative. This is lifelong. This is something you don't fix. It's something you have to work with, and it's all dietary. What do I eat? I mean, dairies you can eat, meats you can eat, fruits, vegetables you can eat, but you can't have any of those type of wheat, rye, barley, or oats in your macaroni and cheese. How about the breading on those chicken nuggets? All those things will really make these children go into severe pain. Now, food allergies we start to see when we start feeding them food. Why do you think at 6 months we give one food at a time every 4 to 7 days and we wait? We're looking for a possible allergy. It could be a rash. I mean, that would be nice. I mean, oh, that is a rash. That is an allergy. Sometimes it's just a little regurg. Sometimes it's diarrhea. So Allergies is something that can cause to the point of anaphylaxis. I think peanuts is the biggest one of all. I know my grandson is a tree nut person. Give him a walnut, and in seconds he'll start to wheeze. So that's the allergy. Now, we do have a lot of intolerances. I think the biggest one, especially when you talk infants, is that lactose intolerance. Now, remember, if we have intolerances and we can't eat certain foods, we are not getting those nutrition that you from those foods. So, for instance, lactose intolerant children, because they're not drinking whole milk, are not getting the vitamin D and calcium. So, we need to think of other ways to give it to the child. So GI dysfunction it causes growth failure, right? No nutrition, you're not going to grow. You're going to spit up, have regurg, nausea, vomiting, diarrhea, constipation. Your tummy's going to hurt, jaundice. Sometimes GI dysfunction is just the inability to chew and swallow. If we look at this one diagnosis called the George syndrome, Pierre-Robin syndrome, he's got these tiny little chins and they have a very hard difficulty swallowing, and chewing is something that they need to go to OT speech, right? To get to know how. So that can cause a big problem. And of course, fever. Fever burns up all of your fluid. So we need a lot. If we're going to be giving a child has a fever, we need to give some extra fluids for that child. As I said, dehydration is extremely dangerous in children. We know when the output exceeds the input, of course, and it could be due to many things. It could be just that insensible sweating, fevers, right? It could be all of a sudden the kidneys start to excrete more, or vomiting, diarrhea. In diabetic ketoacidosis, one of them, and burns. I mean, you've just absolutely burned up all of this tissue and all of this fluid. So what do you see in dehydration? Now I put these two pictures here because they're just so classic. You have a young infant, this is below 1 year old. Their fontanelles, are still there, the anterior fontanelles. And that's the first thing I look at when I see a child. My child's been vomiting a lot. And usually the parents are carrying the child in. So they're a little comfortable. And I look at that fontanelle and you could see, is it sunken or is it where it needs to be? Sunken fontanelle at rest is a problem. But look at that top picture. Look how pale even the ears are, even the nose brim. You can tell just by an assessment. When you see an infant that's dehydrated, their eyes will be sunken. And when you're examining them now, they're going to cry, but there's going to be no tears. It's the saddest thing that you'll see. You're like, oh my goodness, it's crying, there's no tears. Of course, you're going to see those elevated heart rate. Heart's trying to meet up for all that fluid it doesn't have. Lower blood pressure, there's no volume to keep it there. Capillary refill is going to be very prolonged. No urine output. And you might see the point to go into skin tenting because they've lost that fluid. So how do we replace fluids? Well, if they're vomiting profusely, there's no way you're going to give them anything oral. Just not going to happen. They're going to take it and vomit again. So you've done absolutely nothing to correct the condition. Start an IV and then get yourself a basic metabolic profile. Now, why do we need a basic metabolic profile? Doesn't that measure the state of dehydration in the child? Adult, doesn't matter. So we're going to get that, and then we have a baseline of where we're starting from. They're going to be given some antiemetic. Zofran is the one that they love to use. It works pretty good. But they're going to give an IV bolus fluid. Make sure it is never with dextrose and never with potassium in it. Okay? You don't want to overload them with sugar, and overloading them with potassium could put them into renal failure. So we don't want it. Now, one of these telltale signs of have a child admitted they came in with dehydration, you've been treating them, it's 2 days later. What can you look at besides that physical thing that shows you dehydration is correcting? It's your daily weights. It's that everyday weight that they're taking. They took one before when they came in the ER. That's why we always take them. Then they went up to the floor. I mean, a couple little off because scales are all a little different, yes, but you're going to see a significant difference in it. So just with that weight, we can check it. Output, it comes from everywhere. Depending on the child, we can even measure sweating if we needed to. But usually it's intake, output, I's and O's, the normal urine, stools, vomit. But I think it's more of the assessment with that intake and output and monitoring that daily weight that we can say, all right, is it good? Is it bad? Or do we have too much or too little fluid? I mean, that fontanelle in infants is great. It's I can tell right now. And older children, they're not going to be as alert as they should because if they're dehydrated, they don't have blood volume. And the blood volume's not getting all the way up into their brain, right? Because there's no volume. They're not getting the oxygen, and then they get altered sense, right? They're not going to be as alert. All sorts of diarrhea, but basically we treat diarrhea about the same. Now, we're going to be giving fluids to this child. Now, depending on the condition of the child, are they awake and alert or are they drowsy and lethargic? If they're awake and alert, the children can have the introduction of oral rehydration therapy, Pedialyte, Gatorade, Powerade, all of those things. Slow sips, get it in, um, just to start that rehydration. Now, if we only gave fluid to a child with diarrhea, what do you think the diarrhea would be? There's no food. It's going to be liquid. So we need to introduce a diet. And we need to do it slowly and go with, not spicy, easy on the stomach type things. Okay. Now, if the kid was unconscious or, lethargic, that child would get an IV. But most of the time, it's just oral. And then we treat him with some lactobacillus, the probiotic, to replace the bacteria in the stomach. So, constipation. Constipation, believe it or not, is the one thing that children can control. Many children control it because they're looking for attention. Could be something going on at home. It could be abuse, that's of course, but it also could be, something's happened. Maybe, grandma died, or maybe they moved, or the best friend's gone away, or so many things. We don't know what all upsets children, but when we start seeing things like constipation, and I'm talking 7 to 10 days without a stool, and when you take an x-ray of their abdomens, that whole bowel is full of stool. So it's something to remember and to think about because, children should move their bowels a couple times a day. Now, constipation in the newborn. There are really three big things that we need to monitor with newborn constipation. And that's no stool within 24 to 36 hours after birth. Well, it could be that there's a narrowing or there's no opening going down. And that's basically your a big bowel obstruction. Now, Hirschsprung's disease, we're going to go into. It's a piece of stool that the bowel that has no nerves in it. But look at this, hypothyroidism. One of the symptoms of hypothyroidism that's not diagnosed before birth is that no stool, they're going to go check. They're going to pull those thyroid hormones, T3, T4, TSH, right? And then also look, meconium ileus. This is your cystic fibrosis. And cystic fibrosis, yes, we usually know, but maybe they didn't know the father, they didn't get testing, so they don't know. Again, an infant born that isn't having a stool within the first 36 hours, they'll be testing for cystic fibrosis, which is your sweat test, right? So we'll be doing x-rays, looking for that Hirschsprung's, for that obstruction. We'll be doing thyroid hormones, and we'll be doing the sweat test. Now, constipation a lot in children, in infants, usually breastfed, they're stooling all the time. That's just a normal breastfed infant. Now, many times formula fed infants do get constipated, and we don't like to treat them with enemas and laxatives. They like more of even the younger infants. Give them a little apple juice or a little prunes or something very homeopathic, just food. And that usually will loosen them up. And sometimes if we can't get them going, believe it or not, a simple rectal temperature will get those bowels moving. Now, in older kids that are having constipation, I was talking about whole grains, any of those whole grain cereals, brands, etc. Those can help. And also black beans. And, that's for my Hispanic population. I'm here in Miami. So, my children are half Spanish. So black beans, part of their diet. Now, worms. We have roundworms and we have pinworms. Now, pinworms are these tiny, itsy bitsy little annoying pests that usually at night in the dark come out and create massive perianal itching. And you itch, 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 itch. And then these kids can't sleep because they're itching so much. So, what they tell you to do as a parent, go with a flashlight, or if this is in the hospital, we would, as nurses, take a flashlight, go in with a piece of scotch tape, open up the buttocks and find the anus, and put the scotch tape down right in that area and pull it off. And usually the little tiny worms will be on the scotch tape. Put it in a container and send it to the lab, and then will be the diagnosis. The thing with enterobiasis, when one person in the house has it, most likely everybody does. How do we decrease the incidence of this? Keep their nails short. What do kids do at all ages? Everything in the mouth, fingers in the mouth, right? Always. And if their nails are long and they're like little girls and boys like to play outside in the dirt and whatnot, they're going to bring in eggs and it will, infect them. So one of the things is just cutting their nails short. Peptic ulcer disease can happen in kids. Kids are little worriers. Usually it's going to be nutrition that we're going to treat it with, but we can give them those acids like ranitidine. Yes, we don't give ranitidine anymore. We give more of the Pepcid. But according to the book still, it's what it says. So I put it here, but let you know that they have changed. Back in the 90s, it was methadone. So there have been different, actually, anti-acid drugs that have been taken off the market for many different reasons. I've never seen a surgical intervention for a ruptured or a really severe peptic ulcer. Now, hepatic disorders, liver, can be due to many different reasons. But what does the liver do and secrete in nutrition? Well, that's bile, right? Goes into the small intestines, helps with fat digestion, and that gives that nutrition. Well, if your liver is not working right, it's not working with the fat, and it's not being digested. So, diet again, high protein, high carbohydrates. This is just like celiac disease. I mean, celiac disease also needs that good type of, nutrition. Now, we're going to do that low-fat diet because it's the gas, it's the pain, it's the discomfort. So that would help decrease it. But we really need to get those calories in by protein and carbohydrates. So I told you I was going to tell you Hirschsprung's later. Here's Hirschsprung's. So if you look at that descending colon on the right, it's a big outpatch, right? Big and full of all sorts of stool. And the reason why this is going on and getting bigger and bigger is that area of the colon does not have ganglion cells or nerve cells, which means how is that being peristalsis pushing down the food down the intestines the way it should? It's not. It's just sitting there and getting bigger and bigger. Well, then you say, well, don't they hurt when it gets bigger? There's no nerves. They don't hurt. So they can't tell you, because sometimes this is found at birth, many times is, but sometimes it's not that severe, it's small, and it could be the first couple months of life. but usually it is at birth, okay? So when that big, outpatching of that colon is there, we call that a congenital aganglionic megacolon, as in born with it, congenital aganglionic, no nerves, and a megacolon because it's sitting there and it's not moving, okay? Down's children are more common for this than other children. Now, one of the signs that we may see with this is, you see that little piece of rectum down there in the bottom? Sometimes a little bit like frosting out of a froster, like you'd put on a cake, little ribbon type things will come out stools. So sometimes a symptom, you're going to see ribbon stools. And that's why, because the rectum is tiny, and this is just pushing a little through that, like a frosting for a cake. Now, how do we diagnose Hirschsprung's? Well, number one is going to be that child who's not had a bowel movement. Then all of a sudden, we're going to see that abdominal distension. We're going to look at the x-ray, go up, there it is. They might or may not do barium enema, but absolutely a rectal biopsy. They want to find that there's no nerves. So what do we do? Well, that piece of intestines is useless. There's no nerves. It's not functioning. It's actually a hindrance. It needs to be removed. So they do sometimes what we call a two-part surgery, where they take that piece of intestines out and they put an ostomy, a colostomy, and usually it's there for about a year. Now, sometimes they can do a pull-through procedure. They remove that piece and they're able to pull those other two pieces together. It can be done depending on where that aganglionic portion is. Postoperatively, these children, you leave their rectums alone. Okay, it's called no rectal temperatures. And because that intestines has gone through all of this and reanastomosis, they're going to be NPO for quite a few days postoperatively. And if it's an infant, make sure they have their little non-nutritive sucker, their pacifier. They need that. Now, appendix, just like adults, there's no difference. Right lower quadrant, McBurney point, rebound tenderness, and we diagnose it through an ultrasound. Now, how do we treat this preoperatively? Well, as soon as we figure out it's an ultrasound, we know they're going to the OR. We know that we want to have the children with an empty stomach. So preoperatively, start an IV. We want fluids. Make sure that that child has enough fluids, because with their tummy hurting, they may not have eaten. We will give pre-op antibiotics, just prevention, and send them to the OR. Now, if all of a sudden they've gone to the ultrasound, you started their IV, and all of a sudden their pain is gone, most likely the appendix has ruptured. Now, think about what happens. That connection between the small and the large intestines, that cecum, has burst open and spewed all of these toxic materials into the peritoneal cavity. The outside of that intestines is irritated, it's red, it's raw, and it's mad, and it's angry. So, NPO for these children, but also an NG tube down into their stomach. We do not want anything going down into those intestines and irritating the bowel more than it is. It needs a rest. So it's called an NG tube for gastric decompression, sucking out all of those gastric acids. Of course, IVs, because they're not eating. IV antibiotics are key. And then monitoring their daily CBCs they usually get done. What are we monitoring? Their white count. Is their white count coming down to normal? And these children need to be up, out of bed. They need good pulmonary toilet, cough, deep, breathe, incentive spirometry, ambulating. So medicate them. A child is not going to move until you medicate them. Would you do it to an adult? No, don't do it to a kid, because a child won't ask. You're going to say, I'm giving you something. And then you got to be creative in pulmonary care. If I told you some of the crazy things I've done to help all different age children with atelectasis in their lungs, get their lungs open, but blowing a pinwheel, blowing bubbles, I used to do spitballs with the older kids. Get them a straw, put up a target on the wall, and go spit it. Now, older kids that wouldn't choke, not the younger kids. And we make a game of it. But I used to work night shift, so I had that ability. I don't know if I would have done it during the days, but this child that I did this spitball trick with was an adolescent who actually had a trachea reimplanted, had another one put in. Her trach was broken, per se. So it really helped with pulmonary care. It's creative. Be creative with kids. An omphalocele is when the midsection of the abdomen doesn't close, and then a lot of times it's the stomach and the intestines and stuff that just don't get inside. They're in a sac, okay? And all of those organs are born on top. They all work, they're all connected. Well, our goal is to get that put back in the stomach and close it up, okay? Called an omphalocele. What is our major concern? Infection control, right? So immediately we got that's an inside organ. We need to put some nice wet, normal saline, sterile dressing on there. Always wear gloves. You need to keep it open to watch it. So they need to be on a nice radiant warmer to keep their heat up. And then, of course, antibiotics to keep no infection around, IV fluids, because they can't eat at this point until that stuff goes back in. What the surgeon does is he comes every day and he packs it in a dressing. And every day he starts to try to push a little bit of the edges inside of the abdominal cavity. When he feels he has enough, leeway now to close it, he will. But it usually takes up to a week for that to happen. I've seen quite a few of these in my career. Now, intussusception is your younger kids. Actually, the youngest I've ever seen is 5 months, and that was very unusual. It's usually that toddler, 1 to 3 years old, where they all of a sudden are screaming in severe abdominal pain. You can't console this child no matter what you do. Their legs and their arms are just shaking. It's like pinching inside of their abdomen. The intestines suck up into each other like a telescope, is what happens. And then it swells and all those nerves hurt. Now, if I see this happening, as I'm doing an assessment, I want to look at their underwear or I want to look at their diaper. Is there a little bit of this clear jelly, currant jelly stuff in there? That's usually one of the things that gets expelled when it's pushed in like that. And it could be your telltale signs. We're going to do an ultrasound and we're going to find that intussusception. Many of them just all of a sudden come out by themselves and we send them home, tell them increase the fiber in their diet, and usually they do well. But there's some that don't, or they waited too long in the first place to come in, and now they're really swollen and really stuck together like that. They'll either do one of two things with these children. They will do a barium enema, pop it open, and this is the radiologist under fluoroscopy watching this intussusception, or they're going to do an air embolus and it pops open the intestines. I've only seen one in my career that had to go to surgery and have a piece of that intestines removed, but that's intussusception. You don't see that in adults. Now, mecodiverticulum. In the small intestines, there's these little outpouching of tissue things called a little duct. And inside these ducts are big blood vessels. And sometimes they tear. And that creates blood dripping into the intestines, and then you will see painless rectal bleeding. It's very easy. They go in, they figure it out by this radionuclide study, and they remove it, and the prognosis is really good. IBS, again, mouth to anus. It's about two types, ulcerative colitis, Crohn's disease. When we look at them, the treatment is diet, and sometimes it's steroids and sometimes biologics for that ulcerative colitis that needs to be done. Usually diet, if it's done right and stick on it and you're diligent with it, you'll be okay. Ulcerative colitis is a lot of diarrhea. So again, your GI tract is pushing food through, it's not being absorbed, and the nutrition is being lost. So again, nutrition. Short bowel syndrome. Well, gastroschisis and phalocele are the same thing. Gastroschisis is specifically, they say, the stomach, but they're all the same thing that you can see sitting there. But small bowel syndrome, short bowel syndrome happens when a piece of bowel, quite large, dies. Now, this can happen usually in your young infants where you're giving them a tube feed. Happened to my little Jessica at 6 months old. She had status post second stage surgery for her um, left hypoplastic heart. And they put a little feeding tube in with just a little bit to keep her stomach going. Well, all of a sudden, her belly blew up or distended, took x rays, and she had something called necrotizing enterocolitis. Well, that means the bowel is dying and rotting and turning black in the stomach. It is an emergency to get it out. So when they went in, her small intestines, it was either 48 or 58 centimeters, was removed. That's like 2/3 of her small bowel was removed. So you can imagine how much nutritional support this child needs. So you look at that little boy, he's a Broviac in. She had a Hyperal and lipids every night to go to bed, extra nutrition. During the day, she had a gastrostomy tube where they got extra feeds in her all day long. And she still was an extremely skinny little thing because short bowel syndrome. That means it was shorter than it should be. We have hernias all different places. We have stomach, the umbilicus. We have umbilical hernias, inguinal hernias. We have diaphragmatic hernias. And it's basically the intestines goes in a place where it shouldn't. Now, those umbilical hernias that are nice and soft, I like to use to punch them back and forth because they're soft and squishy. That means it's healthy. It's okay. But it can incarcerate, which means it's all of a sudden it's, not moving, or strangulate where the blood supply is knocked off. This requires immediate surgery, or else that piece of the intestines will die. So if you're pushing that cute little belly button and it's hard and it's hot and they scream, it means it's dying. You have a certain amount of time to get that intestines untangled and so it doesn't die. Anorectal malformation. Do you know babies can be born without an anus? Imperforate anus. I never saw one. They're very rare, but no rectal temperatures. Gee, I wonder why. There's no anus. So it is a condition. It's going to require a colostomy pretty quick. And they do multiple stage surgeries to create some sort of anus for this child. There's all sorts of fistulas where things are connected, the stool, the intestines into the vagina, urine into the intestines. I mean, there's all things. And most of the time, it's the nurse who says, oh, there's stool coming out of this vagina. Something's wrong. And you get close and you tell the doctor because they usually don't see it. So it'd be something that'd have to be fixed. So children put everything in their mouth, not uncommon, everything. We know that things like acetaminophen can cause hepatic failure, so liver failure. So that would be an extremely dangerous thing. But plants, sometimes toys, those teenagers with those Tide Pods, I mean, they're crazy to some of those things. Lead is a big thing. Think about a little toddler. They go up by a window and they put their mouth on the windowsill and start chewing, right? Because everything's in their mouth. But if it's an old house, they could be getting lead poisoning. And then they'd have to, if we figure out they're getting confused and nauseous, vomiting, and seizures, well, they might need that chelation therapy. Now, infants vomit. They could be a little dribble, it could be across the room. But if they're vomiting, it's not normal and they're just can't eat, et cetera, et cetera. First thing we do, make them NPO. Stop the food. It's not going to help by waiting. You don't small nothing, stop. That stomach needs a rest. And again, what do? We're going to start an IV. We're going to draw that metabolic profile. Remember, no dextrose and no potassium on the bolus. Give that Zofran. And after that bolus is when we start slowly giving some sort of Pedialyte, Gatorade, or Powerade. Gastro reflux, GERD. This is those kids that they eat and they spit up. There are older children that have reflux. We have adults that have reflux, right? Food goes up into the esophagus. One of the signs and symptoms of it is that cough. And that cough is telling you that child's having many aspirations of whatever food's in there, that abdominal burn and that pain. So that's older kids. Now, younger kids, could be due to something different things. Number one, I've seen is the type of formula they're on. A lot of times they can't tolerate, so they'll be spitting that up. After they figure out they have them on the most desensitized formula you could possibly have, they're still having reflux. They'll probably put some rice cereal, the powder, right into the formula. They put 5 mLs in an ounce. That's a normal thing that they do, and it thickens it so it will hold it in the stomach. Many times they're overfed, they're not burped. They should be sitting up after that they eat, and they should be laying down. Now, infants, adults, children are having this reflux and it's becoming esophageal problems and burning. One of the conditions they can do surgeries is called a Nissen fundoplication. Have you ever taken care of a patient who has a gastrostomy tube? Most of them had a gastrostomy tube with the insertion of a Nissen fundoplication. Now, what they do is take the top of the stomach, flip it open, and it prevents them from vomiting. So you can have a G tube, give them their bolus feed, and they're not going to vomit. You're pretty safe with that. In these children with this reflux and this burning going on, that Nissen fundoplication stops that burning from going up and down the esophagus. It's a very simple procedure, but very effective. Now, I mentioned that you could have spit up, which is most infants. It's one of the questions. Any infant coming into my ER and complaining of vomiting under the ages of 4 months, I'd say, is it a dribble or is it projectile across the room? If it's a dribble, I know it's GERD. If it's across the room, it's pyloric stenosis. You literally can point this infant vomiting at a garbage can 10 feet away across the room, and they will hit the bucket. I'm talking, it is that impressive, okay? Now, they're telling me they're vomiting like this. I will tell them, please don't feed them again. Then I'm going to take my hand and put underneath their xiphoid process, and I'm going to feel what they say olive-sized mass. I call it a marble because it's quite significant and hard. It is the pyloric sphincter that's gotten hypertrophic and muscular and doesn't allow food to go from the stomach into the duodenum. It's that pyloric stenosis, that valve right there. So put them NPO, get them over to ultrasound, get the diagnosis, send them to the OR. Now, these children are not at risk for aspiration, pneumonia. So these children, pre-op, post-op, NPO, IV fluids, they do really well with that. And the reason why I say that is, when I go on, I'm going to tell you why. That only is IV fluids, and NPO. Now, cleft lip is something that when the child is born, can be pretty devastating to a parent who doesn't know it's coming. And even if they know it's coming, cleft lips don't look good. They look, your poor little child looks dysmorphic. But then you look at this cute little picture of this child here, and they look beautiful because they've had their repair already. Now, there's lips and there's palate. When your lips are done, they usually do them early. They try to get that seal around a bottle or a breast, right? Because you can suck. That's what that upper lip will do. So they'll do it at 2 or 3 months. And they use something called that little metal bar that called a Logan bow because they like to smush their face in the blankets and pillows. And we don't want them to rip open that plastic closure that's happened. So this picture is from your book, shows you where all these things are. I have seen bilateral and palate, and they are a feeding challenge. Now, the palate, the roof of the mouth, usually is not repaired. They do the lip first, 2 to 3 months. 6 to 12 months, they're going to do the palate. And they like to do it before a year because if you don't have a palate, you cannot pronunciate, and you're going to have a really effect upon your speech development. You must be talking like this because you can't make it. And that's exactly what they sound like. So once it's fixed, they're good, and these children do well postoperatively. Now, our thing is all about feeding that young child. There are special things. The Haberman bottle here was actually made by a parent, and the top area is extremely soft and pliable. And you put it in the mouth, and that big long space there fills up with milk, and you're able to slowly pinch it in the mouth as you hold their mouth and help them suck. And they get all the satisfaction they need, so they're happy. Breastfeeding is a struggle. Parents literally mother has to squeeze the breast to make sure that they're getting their milk because they can't suck. They don't have that. Now, remember I told you there's one different one. You have your pyloric stenosis for pre-op, and post-op, it's NPO, and fluids for pyloric stenosis because there's not a chance for aspiration. Well, tracheoesophageal and tracheoesophageal fistula both have a chance for aspiration. You know, tracheoesophageal atresia, there's no connection between the mouth, the esophagus, it goes nowhere. It's not connected to nowhere, not to its stomach, okay? Tracheoesophageal fistula connects the esophagus and the trachea. So if you eat or you swallow liquid, it goes directly into your lungs. These are aspirations. These are the children we worry about prophylactically treating any aspiration that they could possibly have. Because even if we're suctioning the mouth out, they're still producing mucus, in their mouth. They're still swallowing, they're still having mini aspirations. At birth, this kid is going to gag, cough, choke, and it may be with that first feed that we give them. Sometimes they give them a little bit of glucose in the nursery. Well, they're going to be gagging and choking it, and that will be the telltale sign. So how do we maintain this? These children are NPO, nothing in their mouth, okay? Head of the bed elevated, suction there in case there's foaming at the mouth, NPO, IV fluids, and antibiotics because these children are having aspirations. They do surgery and they fix them. There's nothing wrong with these children. They're normal children that didn't have a proper connection. That's the only thing. Any questions? A lot of different type of diagnoses, aren't they? They're not totally specific into the adult world. Although when they are, I try to tell you if there is. So who wants to play a Kahoot today? Who wants to win?
I do, but that's a lot of information.
No, I tend to agree with you. That's all right. We're going to learn it again as we go over it again. How does that sound? See, when I do a Kahoots, I'm going to talk with it and I'm going to tell you the whys and the wherefores. So take your phone and take that little code there on your camera, and it will go exactly where you need to be. think there's 48, 49, if I'm not mistaken. Anybody else want to join? I don't look at the results. I don't look at who did what. I think it's fun just to sit there and to try. So don't be shy. All right, we'll get going. Week 8, GINGU. A multi-select. All of the following are signs of dehydration in an infant except what or are. Which one? Signs and symptoms of dehydration. And when you think of dehydration, does it matter an infant, a toddler, an adult, an adolescent? If you're dehydrated, you're dehydrated. Infants, you're going to see the sunken eyes and the no tears. That's different in an infant, but you're going to have decreased urine output, weak, lethargic, tenting, that loss of elasticity, dry, pale skin, elevated heart rate, decreased blood pressure, prolonged capillary refill, right? And of course, that sense of confusion because of the dehydration. So all of these are the same. Adults, children, infants. They're slight subtleties. What is a priority treatment for a child with dehydration due to profuse vomiting? So if they're profuse vomiting, you're not going to want to give them anything by mouth. You're going to start IV fluids. Are they going to be NPO? Yeah, I guess so. But where treatment is the IV fluids, normal saline, Ringer's lactate, no dextrose, and no potassium on the bolus. What is the treatment for an infant with diarrhea lasting for 4 days? Diarrhea, we're going to feed them, okay? Unless this question said the infant is lethargic. So patient condition always makes a difference in how you're going to treat it. Pedialyte for an infant, perfect. IV fluids is when they're severe and now they're becoming more of that lethargic. What acid base imbalance may you see with a child that's having profuse diarrhea? Now, in my Cahoots, you're going to see always at least one acid base question because I have seen HESIs with 4 acid base questions on it. So I want you to really understand what it is. So let's think about diarrhea before I even see these answers because I knew it was going to be split like that. Maybe this will help you remember. In diarrhea, what comes out of the rectum is all of those enzymes that are used to break down nutrients, and they're alkaline. So you're losing alkaline, alkaline, alkaline. What is left? Acid. So metabolic acidosis is diarrhea. Well, let's look at vomiting. When you're vomiting, what are you vomiting? gastric acid. What is left? Alkalosis. It's metabolic alkalosis. I hope that will help you remember them. You're going to see them med surge too and in peds. So I hope it helps. A multi-select. If an infant is not past the meconium stool in the first 24 to 36 hours, what would you assess for? As I've said before, that hypothyroidism, sometimes it's the only time you know. And remember, if infants don't get their thyroid hormone, they're going to be cognitively delayed and they're not going to grow. Cystic fibrosis, again, we're going to need that for nutrition. And Hirschsprung's, we've got a dead bowel that doesn't have any ganglion, any nerves in it. Electrolyte imbalance, when that's not really our concern. It's the other three. That obstruction, intestinal obstruction. Deficiency of vitamin D causes what? Vitamin D is all about rickets. Scurvy is vitamin C, okay? Vitamin D has nothing to do with the others, just to let you know. Sometimes they throw those questions in. A multi-select. What treatment can the nurse anticipate to a child unable to eat or drink anything, profuse vomiting, and diarrhea? Well, we are unable to eat or drink, so nothing by mouth. Remember, if you're profuse vomiting and you can't eat or drink anything, it's rest the stomach, okay? Draw your basic metabolic profile. Let's see where we are in that hydration status. And of course, IV fluids. No dextrose, no potassium. Give them a bolus. A multi. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? So it's ruptured. You're in peritonitis, right? That little piece of cecum has burst and it's spewed all of this toxins into the peritoneal cavity, and your tummy is angry. Now, you don't want complete bed rest. You want these children up out of bed moving because you need to keep the lungs moving. Also, you have intestines that are angry. You need to get them active and moving again. You need to ambulate, right? The biggest thing is IV antibiotics and NG tube suction. Let's keep the stomach, those intestines calm. And then why assess the surgical site? Well, that ruptured appendix is the whole abdomen is now dirty. Now you've closed two dirty areas. The chance for it to dehisce is actually quite large on these children. So making sure that we look at that surgical incision, I've seen them dehisce before. So those things. Passage of urine, usually at night in children who should have voluntary bladder control. What is that called? And it's called enuresis. Now, I want to stop here for a second because I don't put everything in slides. I don't have, the time for all of that. But there's two things here that the concepts I want you to grasp. Epispadias, hypospadias is a male penis. Usually your urethra comes out the tip of the penis, right? Normal. Well, epispadias is somewhere on the top. Could be up top or lower, anywhere. Hypospadias is underneath. And what they do is these children may not, cannot be circumcised. They need that tissue because they're going to do a plastic closure. Somewhere before a year old, they fillet under general anesthesia, fillet the penis open, create a cavity that will go from the bladder to the end of the penis, and then they put in a catheter, a stent of some sort, close it up. They leave that stent in there for up to 2 weeks, and then the urologist will remove it. Our job with that stent is make sure you keep it in a diaper or you're going to get urine everywhere because we don't touch it. We don't spin it. We don't nothing it. Leave it alone. Just measure intake output. A multi. What is Hirschsprung's disease? And remember, there's two outcomes for it. We could either have a colostomy, like this is showing you here, or that we cut the piece out, we pulled it through, and we're able to reconnect it. Either way, I've seen them done. It's a congenital absence of parasympathetic ganglion cells. All that means is a piece of bowel had no nerves. It doesn't work. Get rid of it. And it causes that megacolon. A multi. When teaching parents about Hirschsprung's disease, the nurse would include what? Reading about Hirschsprung's, many of them are found at birth, but some are not as big. So later on, they catch them. We know because you don't have stool moving down because no peristalsis is happening. There's a bowel obstruction. We know that they need to postoperatively monitor those bowel habits, making sure that they are moving it. And then, of course, is that two-stage surgery or pull through. There's two types they can have. And we do not like to treat anything with laxative and enemas. The only time that we will do an enema is if a child has been constipated, as in not moved bowels up to 7 to 10 days. Sometimes that emotional I was talking about, we'll give an enema just to get them started. But from there on, no, we will not. So just like we will not give any oral type things, no laxatives either, no enemas. We don't want them to get stuck and dependent on them as a child. What's going to work when they're an adult? Dynamite? So, what type of stools would an infant with Hirschsprung's disease have? So, we have the big outpatching colon and then the tiny little piece that goes to the rectum. And sometimes a little bit gets squeezed through, and it's that ribbon shaped stools. What is the condition that occurs mainly in children where their intestines scope into itself? And that's what we call intussusception, yes. Gastroesophageal reflux disease, GERD. What is that? I mean, sometimes the name tells us all, doesn't it? Very good. So the stomach, and all of a sudden it refluxes, it goes up into the esophagus. Older children would see coughing, and it would be that pain in that area that would bother them. Inflammatory bowel disease involves what? IBS. Where is it? Any part of the intestine, stomach, small, large, rectum, all of it. It's the whole thing. We could go on and say mouth to anus if you'd like. What would the nurse be looking for when a patient has Meckel diverticulum? Remember, it's in the small intestines. It's a piece of tissue, a diverticuli per se, that rips, right? And what's inside that diverticuli? It's a blood vessel. It is painless rectal bleeding. Well, not bleeding, but bleeding. Close enough. A 6-year-old child goes to the ER due to abdominal pain, fever, vomiting for the last day. What assessment's priority? What else do you need to know in order to take care of that child properly? And I just had my daughter's sister-in-law call me regarding her little 4-year-old boy complaining of abdominal pain. My first question is, tell me, where is the pain? Is it umbilicus? That's gastro. Or is it right lower quadrant? That's an appendix. So it's a medical treatment versus surgery. And you don't want an appendix to wait. You don't want it to burst. So the description of that pain is your most important. What would the nurse expect to see in an infant with biliary atresia? Well, biliary, that is your liver. Atresia A is without, there's no opening into the common bile duct of the liver. So you're not getting bile. So what are you going to see? So that's how you pull that word apart and make it work for you. So no bile, they're going to be clay-colored stools. And because bile does what? It has with fat digestion. You're not digesting fat, your abdomen's going to get large. Very good. What structure of the mouth can be impacted by cleft lip and palate? All the above. Small, soft, hard lip, the whole thing. Cleft lip repair is typically done when? Remember what infants, their biggest thing is all about oral, all about stress relieving. You know, they call it the soother, right? The pacifiers. Some people, that's what they call it. We want that as quick as we can, usually between 2 to 3 months. And they do a really fine plastic closure, making sure the lip is all approximated all the way it should. And when do they do the cleft palate repair? So usually cleft palate, we want it before they start talking, right? Because if not, it's going to impede upon their speech. So 6 to 12 months is when we do it. Esophageal atresia, what's that? So there is no connection between the esophagus and the stomach. So remember the word atresia. A is absent, without. There's no connectioning or no opening. Okay. There's nothing that gets it where it needs to go. So remember what our things about that is? So you can't swallow and eat it, it's going to come out and go into the trachea and cause aspiration. So tracheoesophageal fistula, tracheal atresia, NPO, don't feed them anything. And then, of course, prevent your aspirations. What are the classic signs of esophageal atresia and tracheoesophageal fistula? It's that, okay, you can't have anywhere for the liquid, even in the mouth, to go to. So it goes into the lungs. So it says cyanosis, choking and coughing. Olive-shaped mass, right upper quadrant or mid quadrant, that's pyloric stenosis. That's my marble, okay? Current jelly stools, intussusception, where it pushes out a little bit of that clear jelly with maybe some blood streaks in it, okay? So I say that matching sheet that I'm going to send you will have all that information clearly identified. Multi. Neonate with a suspected tracheoesophageal fistula, nursing care should include. What's our big deal with this? Elevate the head of the bed, and NPO, absolutely. Elevating the head of the bed for feeding so you can give multiple aspiration pneumonias to the child. Nothing, nothing, nothing should they be eating, not even glucose water. It's elevate the head of the bed, NPO, give IV fluids because they can't eat, antibiotics because they're still going to have mini aspirations, right? And have suction at bedside. A 5-year-old child is complaining of epigastric pain and a persistent cough. What would you suspect? And that's your GERD, right? That's the gastroesophageal reflux on the older child. What is ranitidine used for in a child with peptic ulcer disease? As I said, now it's the Pepsis, famidine, famididine. So all it does, it reduces the amount of gastric acid produced so that all that acid's not burning up the stomach lining. That's completely what it does. It's not neutralized, it decreases, it's less. Signs and symptoms of hypertrophic pyloric stenosis are is that is the olive-sized mass right there underneath the xiphoid process. They say it's a little bit to the right, could be in the middle. It's just very close. I call it a marble olive. It's the same thing as, again, if they're vomiting projectile across the room, that's where my hand's going to go and check right away and to see, is it pyloric stenosis? Signs and symptoms of hypertrophic pyloric stenosis. Which one? Projectile vomiting. Now, the thing with this child, you're saying poor appetite. If you could imagine this child, this infant just ate a lot of food and is like, oh, so happy, my tummy's full. Vomits projectile, the whole amount of what they ate across the room. They're hungry again and they're screaming and they want food again. So it's not a lack of appetite. They're hungry. They want more. It's projectile vomiting. Preoperative treatment of pyloric stenosis include again, NPO, start IV fluids. And remember, this one doesn't need antibiotics. It is the tracheoesophageal fistula, esophageal atresia. Very good. What does celiac disease affect? Remember, if you look at celiac disease, what is it? It's a nutritional problem. You have a problem with wheat, rye, barley, and oats. Intestines, nutrition, where is that focused? It all happens in the small intestines, and that is the answer. If you have celiac disease, what would you eliminate from your diet? Wheat, rye, barley, and oats. Oh no, you can have all the chocolate you want. That's not a problem. It's a good thing. Multi. Vitamins that children with celiac disease are prone to lose are, well, celiac disease has a problem with the absorption of fat. Fat vitamins are lost. Which one of those are fat? Everything but vitamin C. Vitamin C is water soluble. What foods would you select for a child with celiac disease? So nothing with bread, right? No French toast. Fish sticks are breaded. They have macaroni that is all some sort of flour. And then, of course, garlic bread. So an omelet, bananas, glass of milk, an ice cream, and a big chocolate bar, right? Phimosis. Didn't mention what this was, but this is all about the male. And it's actually something that happened to my grandson at birth. So sometimes they have a foreskin that cannot be pulled back. It's too tight. And, I've been working in pediatrics and newborns for a while. So my daughter said, go ahead, see if you can pull it back. I absolutely could not. And the problem again with keeping that foreskin closed and over the head of the penis is that future problem that you can have urinary tract infections. So actually, at 30 days old, he had a circumcision only because his foreskin was tight. I couldn't move it. What is a hydrocele? Again, I didn't cover it, but look at what the word says. What is it? It's usually painful. Usually there's on a child who's already been potty trained, there'll be an incontinence. This can happen in young to old adults. They treat it with a shot of Rocephin, and that usually cures it, believe it or not. and then look for an infection. It's water in the testicles, and it hurts. What is a cryptorchidism? Again, this is your male again. Your monkey tells the picture tells 1,000 stories, doesn't it? What does a pediatrician do? One of the first things on assessment on a male newborn infant. First, you're going to check the hips and listen to everything else, but they're going to check to see if the testicles are both in. Now, one of the things about cryptorchidism, one of the questions I would ask, especially if they're getting older now, have you ever felt the testicles? Maybe they felt the left one, but not the right one. And now you're not feeling the right one, but you're feeling the left one. I mean, opposite. I mean, it makes a difference if they were down there at one point or another. They usually up to 1 year, and then they want to make sure that those testicles have descended completely. So you suspect an infant has cryptorchidism. How would you examine the infant? Well, if you're male, you think about your testicles. How do you have them there that are not sucked up higher, that are hanging lower? That's the answer. And you put them in a warm room. If it's cold, they tend to get tight up against the body to keep them warm. And if it's warm, they tend to go away because they don't want to be so hot. And that's your answer there. What was that? A hypospadias. Remember we have epispadias and hypospadias. Well, which one is the word? And again, remember, we usually correct that before potty training, and we cannot have them circumcised. This could be a problem for like the Jewish faith because they want to do their brisk, but it's called the ventral side of the penis. Hypospadias, okay? Epispadias is on top. And they actually, when it's done, you really never knew that it happened. A multi-select. How is that epispadias corrected? Told you a couple times now. What is it? So the surgery is done under general anesthesia because they literally take and cut the penis open and fillet it. Literally, you can't do that under local anesthesia. We're going to use that foreskin for the plastic closure, and we're going to put that stent in to keep that lumen open. And as I said, we don't touch it. We keep it in a diaper because we don't want urine everywhere. So, and usually it's the surgeon who did the surgery that will take and remove it somewhere up to like 2 weeks. I've seen one done, I've seen one with a stent in, and these kids do really, really well. What is bladder exstrophy? It's like a gastroschisis or an omphalocele. I've seen one, I believe it was very, very small. In fact, they came in, did surgery the next day, and it was closed already. It was so quick. But it's a midline closure. The bladder's left up. Our biggest concern about the bladder and things that come out is to keep the skin integrity, keep them moist, healthy, and free from infection. That's our big thing with that. What is a priority nursing care for an infant with bladder exstrophy? We see these things outside, but just remember, inside or outside, they're still connected, they're still functioning, they're still doing their jobs, which I think is remarkable. And the whole thing is worrying about keeping that skin integrity, keeping it free from infection so that when we push it back in, everything will be fine. Bowels are not affected by this. There's no bowels on the outside. And incontinence, no, they're infants. So at this point, all infants are just urinating in a diaper, right? What are the clinical manifestations of nephrotic syndrome? It's all about protein. Again, nephrotic syndrome is not renal failure. The kidneys are working, but the kidneys say proteins, albumin, the other word, I don't like you. And they urinate it out like crazy. So all the protein in the body goes away. When that happens, then you have all this peripheral edema. So hypoalbuminemia, which means low protein in the blood, and low serum albumin, same thing, and the swelling, peripheral edema. Children with nephrotic syndrome are often given what medications for that fluid overall overload? What do we give to try to decrease the interstitial swelling? I mentioned it. Well, think about nephrotic syndrome. Why do we have fluid interstitially? It's because protein levels are low. So let's give some protein, try to increase the level. That will suck in some fluids and then give the Lasix behind it. Okay, make understand better now. What is used to treat nephrotic syndrome in children? What did I tell you the treatment was? Is it supportive? Is it just watching daily weights intake, outputs, um, watching the salt intake, fluid restriction? No, all of those are always in a constant. We'll give prednisone in those acute stages when they're really swollen. A child's admitted with acute familiar nephritis. What recent illness could validate this finding? Sometimes the parents don't remember if the kid have a sore throat or not. Well, maybe for a day, but they're confused. There is a test called an ASO titer, and it has strep in there, anti-streptolysin test, and it will show a positive finding. So even if we don't know that they had a sore throat, we can find out if we think that this is an acute stage and what it's coming from. But it is that strep infection that causes it. It's none of the other, okay? What is the priority nursing care of a child with nephrotic syndrome? What's our concern? Well, remember, they're a little immunosuppressed, so we're going to worry about infections, right? We're going to do good hand washing around these children, wear a mask with a little cough. But it's all about daily weights, intake, output. We want to make sure they're not getting more swollen, and that, as in a nursing situation, they're admitted in a hospital. We're trying to decrease the amount of fluids. So we want those daily weights to be lower every day. We're going to decrease salt, decrease fluids. Blood sugars have nothing to do with nephrotic syndrome. And ambulate, you can or can't. Why is erythropoietin used in chronic kidney failure? What's erythropoietin? And why would a child with chronic kidney failure need it? I thought we had erythropoietin being made in the kidneys, right? Well, in chronic kidney failure, the body's not doing what it's supposed to. Part of its job is to secrete erythropoietin, which makes red blood cells. So if kidneys aren't doing it, we are going to give erythropoietin subcutaneous injections, and that's going to help the body produce red blood cells and decrease the amount of blood transfusions in the long run that this child is going to be needing. A child with chronic kidney disease can have renal osteodystrophy. What can this do to the child? Well, what is osteodystrophy? Osteobone dystrophy means maybe like a dysmorphic, not the way it should, right? An abnormality. So, yes, with osteodystrophy, you're going to have those skeletal deformities. It also causes what we call high parathyroid levels. Remember, parathyroid has everything to do with calcium, right? Parathyroid, only calcium. So, if we're having problems with chronic kidney disease, they try again to give more calcium, and that's not always the answer. And of course, you're not having all the things that you need. Growth retardation comes in there also. Uric acid has nothing to do. That's more with gout that we don't really talk about. A diagnostic finding of acute glomerulonephritis may be, well, what causes or can cause acute glomerulonephritis? That's that positive ASO titer that I was just talking about. It's trying to get you preempt and see if you heard it, but you can see strep right in the middle, and it shows you, yes, there's been strep in this body. Which complication of peritoneal dialysis is most important to look help for? Peritoneal dialysis. I've actually, the first day I walked into the newborn ICU at the area hospital, they had a child on it. And that day they were doing a class on it. So I worked nights, stayed awake, and went to it. It just really interests me what was going on with it. And it's a machine. Set it up and you just monitor the child. The peritonitis, again, no abdomen, no peritoneal cavity, there's no kidney, there's no hemodialysis on these children, and the children will die. So we got to be really, really diligent with our care. What clinical assessment is most important to report? A child diagnosed with an acute kidney trauma. Now, I saw a child, it was about a 9-year-old boy, was playing hide and go seek or whatever it's called today, was running around this camper and ran into a trailer hitch on his back at the level of the kidney and had this huge bruise on his right area. When we brought him in and we did electrolytes, he had a potassium of 7.6. He had a fractured kidney. And we could tell just by that electrolyte standing. So the biggest thing, kidneys, you always electrolyte, always think potassium, okay? Always, it'll always be right. Multi. What should the nurse anticipate for a child who just had a renal biopsy? Remember, I said there are similarities between renal biopsy and cardiac caths. Both has had some needle punctured in an area that we're concerned about, right? Absolutely. But we put it into a kidney. So now intake output, really important. Kidney's all about fluid balance. Bed rest 24 hours. You don't want them up. You don't want them to dislodge any clots. You don't want them to have urine into their peritoneal cavity or blood. That just create more problems. And that's why we monitor that dressing. No ambulation for 24 hours. What would you do if the fluid draining from the peritoneal dialysis has changed color and now it's cloudy? Like, why did it do that? Call the doctor, let them know, and guess what's going to happen? You're going to have antibiotics that we're going to start so you can anticipate. And our job is to get them started as soon as we possibly can. Very good. Last question. What would the nurse provide to an infant that cannot eat normally? How about that tracheoesophageal fistula? They can't eat because they're going to aspirate. What for growth and development do infants need? How do they soothe themselves, right? What does how do they explore their world? Everything in their mouth. They need a pacifier. I know many years ago it was like they're good, pacifiers are bad. No, they're good. Well, now through a lot of research, they're self-soothers, and children do need something that they can soothe themselves with. So that's the reason. Number three, Lo. So like J Lo. Look at you, Paul. Good job. Who didn't know what to do? Number
Yeah.
one,
Oh, thank y'all.
Caitlin.
Thank you very much. Way to go,
Thank you,
Caitlin.
David. Robin and Catherine. So these cahoots afterwards, I think, are an immediate testing of your knowledge. I absolutely do them and love them. I think that you, as students, are getting that extra type of explanation, maybe in a different way to help you through it. Now, those of you in Professor Morris's class, I'm going to send you the recording. I'm going to send you the cahoots. I'm going to send you my PowerPoint, and I'm going to send you that GIGU matching so that you have it also. And anybody who needs help with that pediatric assessment project and you feel bad trying to contact Professor Morris, number one, she doesn't mind, but send it to me. I'm home. I just had a week with my grandchildren. So I'm at home all weekend. I'm here to do what you need. Again, Paul, if you need help with math, let me know. I'm here. I'm here all weekend. I can help with anything that you do need. And I'm going to send you that math sheet too. Anything else, my dears? That's all I got. I go straight through and we get you out early. And I know that's what most of you want. So you all have a great weekend. It was nice seeing you all. So remember, I'm here. Don't be a stranger, okay?
Thank you. You have a good evening.
Thank you.
Ew. Oh, you're so welcome.